It's my pleasure to introduce our next speaker, Goldin Joghataie, who is going to talk about assessing the impact of falls on neuropsychiatric symptoms in patients with neurodegenerative disease. Goldin completed her undergraduate degree at the University of Toronto, double majoring in neuroscience and cell and systems biology. She's currently a master's student at U of T Institute of Medical Science, studying neuropsychiatry, falls, and concussions in older adults, supervised by Dr. Carmela Tartaglia.
So hello. So assessing the link between falls and neuropsychiatric symptoms in patients with neurodegenerative disease. So I'll first just talk a little bit about falls and concussions and neuropsychiatry, and then I'll introduce what I've done to date in my first year of master's studies. So falls are the most common mechanism of injury faced by millions of older adults and those with neurodegenerative diseases each year. Patients with neurodegenerative disease, such as Parkinson's disease or ALS, are at much higher risk for falls due to their motor, gait, or balance issues that come with their disease. And the risk of recurrent falls is 3 to 5 times higher in cognitive impairment, a common symptom in many neurodegenerative diseases. Now, a study by Lee et al. In 2020 showed that 82.3% of older adults with cognitive impairment and 70% of those without any cognitive impairment fell in the past year that they did their studies in. So these are very high numbers. Now, falls are also the most common mechanism of acquiring a concussion or an MTBI. And, partly it's because the population of older adults is the fastest growing population, and concussions are now more prevalent in older adults than they were in infants before, making falls a current public health hazard. Now, how can one get a concussion from a fall? Many people have described concussions now, but an important thing to consider is that the acceleration in a fall can lead to enough force to shake the brain within the skull. And the amount of force or acceleration can have different impact on the brain depending on your age, frailty level, disease history, if you've had previous head injury. And this really puts older adults and those with neurodegenerative diseases at a much higher risk than a healthy individual who experiences the same incident. And so there are many gaps. First of all, the referrals to concussion clinics for this demographic of older adults and those with NDs is less than 1% in a study that we haven't published yet, but this is a very small number. And you might ask, why is this the case? Well, many falls go undetected. Dementia is a common symptom of many neurodegenerative diseases, so patients might forget to tell their caregivers. Many patients are afraid that their independence might be taken away if they tell their caregivers. For example, they might say, okay, now it's better if you use a walker, and they may not want to do that. Older adults would love to age in place more often, and so they're afraid of institutionalization sometimes. The pandemic has also led to many delays in visits to clinics. And really with concussions, it's mostly that people don't get hospitalized. So we also don't have data from that either. So concussions are often missed. Another thing to consider is that most studies on brain injury have exclusion criteria that exclude older adults and those with previous neurological conditions. And this means that this really limits generalizability, and we need to think about the treatments that we currently have and how they apply to older adults. And there's evidence that concussions are themselves a risk factor for dementia. And dementia is a prominent symptom of many neurodegenerative diseases. So it's really important to have more studies in this area. So symptoms of concussions, you've probably seen this a lot today. But these symptoms usually resolve within 2 to 4 weeks, depending on your age, etc. However, as much as 15% of people suffer with persistent post-concussion symptoms. And these include physical, cognitive, or neuropsychiatric symptoms, which is our focus. Currently, there are no diagnostic markers for concussions, and diagnosis is made clinically. And so you can see the Glasgow Coma scale, which is often used, but this scale is really problematic when it comes to those with neurodegenerative diseases. Imagine someone with Parkinson's disease comes to the clinic and they would already score really low on for example, the motor response tasks. And so if they've had a concussion, you don't know if it's because of the concussion, if it's just their baseline impairment. So it's really hard to look through these confounds. But just because it's hard or it's hard to diagnose doesn't mean there's no use in diagnosis. It's really important to diagnose concussion in this demographic, because even in severe TBI, patients who are older or those who have ND have been shown to recover very well. And another risk of misdiagnosis of concussions is that the physician might think that this is a progressed form of the neurodegenerative disease that they have, like a more severe progressed form of, for example, Alzheimer's disease, where it could just be the concussion symptoms. And if they're recovered, the patient can go to baseline. And so caregivers and family members must really look out for symptoms. If the patient goes unconscious after a fall, if there are random bruises, sudden mood changes, these are really important. Now, with neuropsychiatry, the prevalence of psychiatric disorders in PSC are very high, as much as like 60% anxiety and depression. And the more concussions you have, the higher risk of these disorders. And you can also have more than one of these symptoms if you've had a concussion. And there also could be comorbidities, overlaps. And an important thing is that there could be undiagnosed disorders, for example, anxiety disorders that a person has and they're not diagnosed. If they have a fall, they have a concussion, and then these are aggregated. So it could be the worsening of premorbid psychiatric conditions as well. And now I'll introduce the Andre study. So first of all, the question that we want to ask in the study is that for patients with neurodegenerative disease, are there any differences in neuropsychiatric symptoms between fallers and those without falls? And our hypothesis is that those with falls would have greater neuropsychiatric symptoms. And so this is the Andre study. So the Andre study is a longitudinal multi-site observational cohort study. It looks at 5 groups of patients with ND, so Alzheimer's disease and mild cognitive impairment, ALS, FTD, Parkinson's disease, and cerebrovascular disease. And so patients were assessed across 7 different assessment platforms. We looked at clinical and neuropsychology, but patients were assessed annually. And for ALS, due to the unfortunate speed of disease progression, they were assessed every 6 months. So this is the NPI questionnaire that we looked at. So there are 12 symptoms, and these 12 symptoms were rated based on severity and partner distress. You can see severity is 1 to 3, and then distress is on a scale of 0 to 5. And so we looked at 12 symptoms here. And we also looked at if the patients had falls in the past year, yes or no. So we had 480 total patients in the groups that you can see under there for each disease. And so we saw that out of all the patients that we had, 169 had falls, 311 patients did not fall. The average age for both of these groups was almost identical at 68 years, and the percentage of females was similar at 36% and 32% per group. And so first, some demographic-based results. So there was no sex-based difference between fallers and non-fallers, and there was no significant difference in cognition for fallers compared to non-fallers. This was also the case within disease group as well. So these 2 confounds were kind of cleared in this step. But we looked next at the total NPI scores. So all the 12 symptoms, anxiety, depression, and all the other 10 symptoms, we looked at the total score from all of those to see if they were different between fallers and non-fallers. And we saw that yes, pretty significant, 0.03, 0.003. They were significant for people who fell compared to those who didn't fall. And then next we said, okay, maybe there are a few symptoms that are driving this difference forward. Maybe it's just 1 or 2 symptoms, a few symptoms. So then we looked at each of the 12 symptoms. So the impact of fall per NPI symptom. And this is what we saw. So first of all, you can see here that depression, apathy, disinhibition, nighttime behaviors, and appetite were significantly different between fallers and non-fallers, but our p-value was less than 0.01. So we couldn't accept these as significant, although they were important to note. What we could accept as significant was anxiety, very significant, 0.0002, more frequent in fallers than in non-fallers. So now anxiety is more frequent in fallers than non-fallers. Next, we want to ask, is anxiety severity and distress, are the higher scores more frequent in fallers compared to non-fallers? And we saw that yes, this was the case. So the people who fell had more frequent scores of the higher in the scale of severity. So as you can see here, for severity 2 and severity 3, the people who fell were the only 2 rows that had more frequent severities, higher severities than those who didn't fall. This was also the case for anxiety distress. So next, we wanted to look at this further. So we saw that we asked, okay, who has the most falls? Which group has the highest frequency of falls? And those were those with ALS. So the people with ALS had a very significant higher frequency of falls compared to other NDs. And then we asked, okay, is there any group that has higher frequency of anxiety compared to other groups amongst fallers and non-fallers? And we saw that yes, those with anxiety very significantly, as you can see at the top for the p-values, FTD had more frequent anxiety presence than all the other groups. And so then next we looked at all the fallers now, and we asked, okay, so amongst everybody who fell, is there an ND that had significantly more anxiety than the other groups? And we saw that yes, this was the case for FTD again, with more people who had anxiety if they fell compared to non. You can see that FTD is the only one that has a percentage higher than 50%, which means it's the only one that's flipped. So more people anxiety with more falls. And so we concluded that anxiety frequency, severity, and distress were significantly higher in fallers compared to non-fallers. And amongst all those who fell, those with FD were more likely to have anxiety. And neuropsychiatric symptoms can occur after a concussion, but we cannot ascertain if patients had concussions because we didn't see them directly in this study. But missing a concussion, as mentioned, can be a missed opportunity to treat reversible symptoms. Now, there are a couple limitations of the study that participants may have had varying post-fall treatment, so we don't know what happened post-fall. Someone may have gotten treatment, someone may have not. We don't know the exact time of fall, so we do know it was in the past year, but we don't know when in the past year they fell. And some patients may have had concussions after a fall, and anxiety is a post-concussion symptom, but we will have to clarify that. And for our future directions, okay, so we'll go to the first. So this is just a diagram to show that we may have seen a significant relation between falls and neuropsychiatry, but we really need to ask how this might tie into concussion directly. So for our future directions, we are aiming to do a direct analysis of this to kind of have patients who have had falls and those who have NDs, and ask them specifically if their head is, if they had how they had a concussion, if they had symptoms, and how they fell, basically, to directly assess this. And I just want to quickly say something is oftentimes people consider anxiety and irritability, depression, or attentional bias to be like grouped in the same kind of summary of things. However, this interesting study has shown that anxiety is its own very independent problem that should be looked at post-concussion. Often it's grouped with attentional bias to threaten athletes, but here it's shown that it was just anxiety and not attentional bias to threat that was elevated in concussion. You saw that specificity there, so I think it kind of might relate to our study as well later on. So yeah, I just want to thank Dr. Tartaglia and her lab and all the Andre investigators. Thank you.
Talk trying to tackle that complexity. Do you want to just stay for a moment in case you have any questions? Yes, you do.
Hi, so, I don't know if this is working. I will project. So you kind of framed this as the anxiety that you're seeing could possibly be a symptom of the concussions that may have occurred. And you kind of touched on this at the end, but what do you think about the possibility that they're anxious because they're just falling more and they're worried about falling?
Yeah, that's a post-fall issues. That's a really important point, and it's also could be because we saw that those with ALS were the ones who had more anxiety, regardless if they fell or not. So it could also be that it's the disease that has something to do with anxiety that leads them to fall or not. So this is something that we have to clarify in our prospective study that we're doing later on. But regardless, 1% referrals to concussion clinics is a very low number, and we can't, we can say that in all the people who fell, there's at least maybe some people who have had concussions. So kind of looking at maybe the MPI symptoms that are mostly usually seen in older adults who fall. Usually they have a lot of anxiety and depression after events that happen. So we thought that would be a good thing to kind of focus on first before.
Okay, great. Thank you again very much. Very interesting.